Hello, my name is Lindsey Purcell, and I'm going to present over health inequities in dialysis care, a scoping review. In the US, there are approximately 786,000 patients with end-stage renal disease that require renal replacement therapy in the form of dialysis or kidney transplantation. Access to dialysis continues to be largely dependent on a patient's financial resources, meaning there are many factors that may contribute to one's ability to obtain dialysis care. Factors such as education status, income level, gender, race, and ethnicity can directly influence a patient's health outcome and are classified as health inequities. And especially when a patient has more than one of these specified factors, the health inequity that they experience exponentially increases. Specifically with renal disease and kidney dysfunction, there are three leading causes that contribute to the kidney dysfunction, specifically obesity, hypertension, and diabetes, which all disproportionately affect people of color, lower socioeconomic status, and older age. Thus, the aim of our study is to look at existing dialysis research and identify health inequities reported upon them. In our scoping review, we identified potential gaps in the current literature and explored future research that could contribute to more equitable care. Using JBI and PRISMA with the extension for scoping reviews, we conducted a scoping review on health inequities in dialysis. Using the PubMed and Ovid Embase research banks, we conducted our scoping review in July of 2022, looking for articles published between 2016 and 2022. To identify health inequities reported upon that are defined by the NIH, specifically race and ethnicity, sex or gender, LGBTQ plus identity, underserved rural populations, which we also identify in our tables as geography, education level, income, and occupation status. Frequencies of each of these health inequities, as well as trends over time of the four most examined inequities were examined. In our tables within this middle section of this poster, if you look at figure 1, this breaks down the different inequities within our papers. As you can see, race and ethnicity were the most reported upon, while LGBTQ plus was only identified in one paper. In figure 2, we identified the types of studies that we saw within our 69 included studies. Figure 3 shows our 4 most reported upon inequities and the year of publication in which we saw them. Figure 4 further identifies that specifically with our most reported inequity, race. Table 1 gives you a specific numbers regarding the inequities reported upon. And figure 5 shows again the race inequities reported in the publication years. Concluding our study, we found that gaps were present specifically in LGBTQ plus identity reporting and patient education. Literature on inequities in LGBTQ plus patients' experience is lacking and needs further investigation because there is no standardized method for LGBTQ plus data collection. Patient populations continue to have high disease burden and reduced participation in healthcare research. Implementation and cultural competency training for providers and dialysis center staff may help increase trust within the healthcare system and improve patient outcomes for the LGBTQ plus community. Education was another inequity, as mentioned before, that we assessed and was reported in less than 10% of our included studies. Further research on patient outcomes following implementation of educational and community-based programs to improve patient understanding of dialysis treatment is warranted. Thank you for listening to me today.